Dr. Winter, what is high-risk DLBCL?
There are certain aggressive lymphomas that are more high grade. And what in recent years, we've identified a subset that have genetic changes in certain genes that lead to a very aggressive type of lymphoma that grows rapidly and is more difficult to cure with standard therapy. And what's most important about identifying that subset is that it requires that, at least most of our evidence is that the standard strategy that I just spoke about briefly in terms of that we use for transformed follicular lymphoma, the standard therapy we use for diffuse large B-cell lymphoma called R-CHOP, or the R standing for rituximab. Again, that antibody that targets a particular marker on the lymphoma cell, CD20, immunotherapy plus chemotherapy, CHOP chemotherapy, which has been around for 40, probably 50 years. This very standard backbone of treatment for diffuse large B-cell lymphoma is not sufficient. We generally we don't have head-to-head randomized phase 3 trials showing definitely that the more aggressive strategy is, so much better. But most of the evidence is that standard R-CHOP just doesn't do as well in curing these highly aggressive and what we call high grade or double hit lymphomas. These are lymphomas that have these genetic changes, rearrangements in particular genes, MYC and BCL2. And I like to think of it as MYC takes the brakes off growth. So it's sort of a rapidly growing disease, and BCL2 prevents the cells from dying. So between that, you have a rapidly growing lymphoma that doesn't stop. And so that's a special subgroup of diffuse large B-cell lymphoma. There's some other subcategories, primary mediastinal, which tends to be a type of aggressive lymphoma that's presents generally as a big mediastinal, a mass in the middle of the chest, usually younger patients, more often women than men, but still many, many men as well. So high risk generally for me means that it is a double hit. There's MYC, MYC, and BCL2 genetic changes. There's some other types, but that's basically what I think of in terms of high risk. When we think of garden variety diffuse large B-cell lymphomas, there are some ways of categorizing patients into 4 different subcategories in terms of, quote, risk. The first of these was what we call the International Prognostic Index that was developed in the 70s based on patients who were enrolled on clinical trials. In those days, the diagnoses were probably not exactly what they are today in terms of what category, how we categorize patients, but that it's a set of clinical features that, there's a little app online and you can calculate whether a patient is high risk, intermediate, low intermediate risk. And these remain, this system remains fairly helpful, predictive. but we have refined it significantly in modern times. And I have to say that, not to toot my own horn, but one of my fellows, Dr. Zhao, and I, a number of years ago, using a database from the National Comprehensive Cancer Network, and patients who were all treated with modern therapy and were diagnosed, with modern techniques, we used that data to develop a new, improved international prognostic index. And this helps us better discriminate the different 4 different categories. And it places greater weight on patient age, which is an important predictor, as well as the particular blood test result, the LDH, which is an enzyme that's helpful in aggressive lymphomas and diffuse large B-cell lymphoma. And this particular, what we call the NCCN IPI, you can just put your age and LDH level and so on into this app where you just find it online, NCCN IPI, and it will put patients into 4 different subgroups. And this predicts outcomes and survival over a 5-year period for these patients. It's not hard and fast like anything else. I mean, within every category. So if you fall into you look at every patient in the low risk group by the NCCN IPI, there still are a few patients who will fail therapy, but the majority of patients will do very well. And if you happen to be someone who's 80 years old with a high LDH and you fall into the high risk patient group, the outcomes are not going to be as good, but that doesn't mean every patient in that category fails treatment. So there's still going to be some good outcomes. So it's helpful. These are guides, and they do help to identify patients who are what we call high risk or high intermediate risk. So this is another way of looking at predicting outcome apart from looking at whether a patient is what we call a double hit lymphoma. So the double hit, I just want to make one point, is that when a pathologist makes a diagnosis of diffuse large B-cell lymphoma, it is absolutely critical that by biopsy, the pathology be sent for a procedure called FISH. Okay, that's fluorescent. That stands for fluorescent in situ hybridization. And it's a technique the pathologist can use, or special labs will use, to identify those patients who have this very high risk subset of lymphoma called the double hit, with both a MYC and a BCL2 rearrangement. Whether a MYC and a BCL6 rearrangement falls into this same risk group is a little bit, we're de-emphasizing that. And really, it's the double MYC and BCL2 group that's the highest risk.